So specifically to the retux, I mean, there's no, I can't think of a logical, sort of explanation why might that be the case, unless, of course, that, there is secondary inflammation and it just so happened to, respond to retux, or it was going to just get better transiently over time before the deterioration again. So the answer is I don't really know. But for the mitochondrials, I've been caught out more often than not that, you get a 10-day improvement. So maybe that lesion was inflamed, you got a little bit of improvement, and then it got worse again.
Okay, and would you think of HLH?
Oh, would I think of HLH? Of course, now I would. I hope you didn't. I hope you hadn't secretly emailed me, and I hadn't thought about it, and then you kept that email as a proof that I hadn't thought of that. No, yes. I think particularly now when there's so much, sort of coverage and it's the next thing, I think we just got to be careful as well that we don't over-call HLH. So I'm run one of the meetings in London, and virtually everything, we can't make a diagnosis of everyone saying, oh, could this be HLH? I think you've got to have some criteria, as you said, the key being, an active brain lesion or some regression of skills rather than just a few blobs here and there in a well child.
And no one would believe me.
Thanks.
Okay, any other question? So we come to the last presentation in our session, again with Professor Lim. It's my honor to present him in this very attractive presentation with very attractive title, MS and Relapsing Demyelination Syndrome, New Management Strategy.
Thank
you.
We
are very excited and eager to hear from you again.
Thank you. Yeah, so this is a condition that I feel more comfortable with because it's something that we see, quite a lot of in the UK. And I'm going to talk predominantly about two conditions. One is MS and one is MOG-associated disease. Again, these are my conflicts of interest. So the overview is mainly to give you a higher level view of how common it is in the UK, but of course you may have different, demographics. It's going to flip the coin in terms of early escalational treatment to a more oncology model. I'm just looking at where our oncology colleagues are. So we learn a lot from oncology colleagues, whereby you have more of an induction model and then you de-escalate to a maintenance. And we've been quite behind in that in many, conditions. And then because we're treating more aggressively at the outset, we just have to be careful we don't overtreat. So we need to learn to de-escalate, treatment. So if you look at acute inflammatory demyelination, you know that after the first event, you categorize them according to where there is inflammation or whether it's polysymptomatic. At relapse, we've learned over the years now, particularly in the last decade, that a big proportion of children that we historically diagnose as early onset MS, very young children, 5, 6-year-old, they have, larger lesions, they are band negative, are essentially MOG, antibody, positive. And in a recent survey, so we did a survey of all children presenting with demyelination 10 years ago, and we looked at the outcome of them more recently. And it gives you an idea that about 50% of children that we see with relapsing demyelination, 19% of the total that presented is MS. Slightly less is MOG, and then NMOSD, aquaporin 4, about half of that number. So that's the sort of numbers. I have a Malaysian fellow with me now today, not today, but in the UK, and she tells me that this proportion is the other way around, in that they have more MOGs, more aquaporin 4, and virtually very little sort of MS. So just be careful, and I'd be certainly interested to know what your sort of demographics are. But from the questions, it's quite echoey, isn't it? And from the questions that I get from you all, you appear to see a significant sort of amount of MS. So treating acute demyelination has gotten sort of more profile recently because of the advent of, data about treatment. So this was my slide that I was going to show you, that steroids are steroids. And this is borrowed from an asthma an article. And for every steroid, you can look at the anti-inflammatory, the mineralocorticoid effects, and the equivalent sort of glucocorticoid effects. So this is the bone and all that effects. I can send this to you all instead of taking pictures. But so if you look at the list there, it also gives you the duration, of action, as I mentioned. So prednisolone that is dose equivalent to hydrocort. You just convert that 20 sort of over 5 as such. So you can work out. So for me, the OMS dose of dexamethasone of 20 milligrams per meter squared is about 15 milligrams of steroids per day. So roughly you can have a think about that. And the oral, versus, I'm just going to speak loudly so that you don't get so the oral versus IV dose. They cannot hear. Okay. So the oral versus IV dose, we've talked a little bit about already, that, if you look at an equivalent dose, particularly in treating acute demyelination in MS, it is equivalent. So there's no reason to give IV. So historically, we used to admit all our kids, give them IV, doses, 5 days of hospital stay, unnecessary. Now they just get a CNS. So we do have clinical nurse specialists in inflammation as well. We seem to get a lot of use from our clinical nurse specialists, much in counseling and everything else, but they just write a prescription and they get an oral a dose. And then the speed is important. So I talked about this, already, particularly in both MOG and ON. Remember, your adult ophthalmologists are very used to treating ON that is due to MS. ON that is due to MS, the outcome from treating the acute inflammatory episode of ON to the final outcome isn't brilliant. So because of that, they tend to stick to that, ON by 3 weeks. If you don't have to treat, you don't treat. But don't forget, for our children, a lot of them could be due to other, causes like MOG or, aquaporin 4. And this is the pivotal study that we quote and quote and quote and quote, sort of again, about the benefit of plasma exchange. It was done many years ago now in adults, 20 patients. They even did sham plasma exchange at that stage, demonstrating that there was an effect on mortality rather than the other sort of effects. So I already mentioned that it's really important to consider this in demyelination, but also that it is effective in MS. And we're starting to rethink this paradigm again as well. So in patients, particularly with a certain type of pathology, and this is from Lucanetti's group, and you know that some MS, they have different patterns. One is a T cell pattern, one's a B cell pattern, one's a mixed complement pattern, and it's the B cell complement pattern of pathology, this is, that appears to respond, quite well to PLEX. So pragmatically, if we have a very sick, child that has got a very dense sort of hemi, we would still offer them, PLEX, even with an established, diagnosis of MS, on the basis that it will improve that demyelinating event, although may not prevent, further, episodes from happening. So think about that. So in a very disabled child, and again, just beware that the diagnosis has to be established, because you don't want it to be a wrong diagnosis of someone who is progressing. But of course, if you've done the PLEX and then it's progressing, then you need to think about all the other, causes. And I think PLEX is very well tolerated in children. This is a nice review that our team did based on our institutional data, and it's a matter of the known side effects. So if you've got hypercalcemia, you've got hypervolemia, and if you prompt all that, if you exclude all that, the risk of it is essentially infection and thrombosis from the line. Of course, in a very sick child, as earlier on, you can see that after 2 or 3 exchanges, they might get hemodynamic instability, particularly sort of in intensive care. So those are the groups that you need to be careful about. But otherwise, it's well tolerated. So acute treatment, out of the way. I think a lot of you will have seen a similar case, and if it's not so frequent, it'll be etched in your sort of memory. This was the first girl I saw with MS as a consultant, actually. She presented with bilateral optic neuritis, and 3 years ago had a very similar cerebellar syndrome for which she was not walking, for about 3 weeks, but stayed in bed and didn't go to hospital. I don't know why. And there's a strong, family history of neuroinflammation. I did think that the mother essentially had MS rather than, cerebral lupus for certain. And this was an MRI. You can tell that, there are lots of, areas of demyelination. We'll come back to that a little bit later. She responded, quite well to one course of steroids. And then unfortunately came back later again, 3 months later with the second event. And even in that short span had started to lose, quite a lot of skills, stopped playing the violin and ballet. And it was only at that stage that we'd done the neuroinflammatory screen with the oligoclonal bands being positive, and her imaging at that stage demonstrating newer sort of lesions, so dissemination in space initially and dissemination in time subsequently. And this is, multiple, sclerosis. And you will know that the many criteria has gone by, the McDonald criteria sort of sticks, and essentially all the subsequent criteria has just relaxed your ability to make the inference of dissemination in time. As such. So we know that McDonald 2010 can be applied in children, because the last thing you want is having a criteria that's so adult-based. But you have to be pretty careful when you apply this, in that if patients with ADEM or recurrent ADEM, or maybe even HLH, would fulfill this criteria if you're not careful. So they have to be, you really got to suspect MS. So the diagnosis of MS is made really to institute, treatment as such. So we now talked about the reiteration, and the latest one is 2017. And the 2017 criteria, the key bit is allowing you to use oligoclonal bands as a marker of dissemination, either in space or dissemination in time. You can't use it for both. You can replace it for one. So you need 2 or 3 lesions or lesions in a lot of the brain. And then if you do not have dissemination in time, if you're oligoclonal band positive with the 17 criteria, you can make a diagnosis of MS and you can start treatment as such. So the driver, as I was trying to impress on you, is that because we have more effective treatments, we're able to make the diagnosis, or we should be making the diagnosis, sort of quicker. And we've shown that, there's the improved diagnostic criteria. And there was always a worry that very young children, pre-pubertal children, you would not be able to use the criteria, but we've shown that you can use it equally well. And the pickup of the extra, 40, 50% is essentially the bands. So you can see there that if you use the 2010 criteria, it's the bands that make you be able to diagnose 2017. So we almost make sure that everyone with a suspected inflammatory demyelination now gets intrathecal bands to be measured. But you mustn't forget as well that in patients with ADEM, about 30% of them do have an intrathecal band that is positive, that then becomes, sort of negative. So don't put all the eggs in one basket as, sort of usual. So what do we know about pediatric MS? We know that compared to adults, it has a higher disease activity measured by relapses, and also measured by the number of lesions in the brain. Children can accrue 6 to 9 new lesions each year as we speak. And it's sort of difficult to imagine that, accruing those cannot be bad for you. But yet the juxtaposition of this is that most of the children that we see have a very, very good EDSS, meaning that they've got virtually no, disability at all. So this is difficult bit about pediatric sort of MS. So we get a lot of retrospective diagnosis made in children with soft, symptoms. And when you examine them, they really do not have clinical signs. It's not that you're missing, something. It's just that the signs are difficult, to pick up. We know from, and this is from Lucanetti's group again, that from a biopsy of the lesions in pediatric lesions, and we've known this for many years now, and it's the real reason why we've not acted on this is because there hasn't been very good treatments. But since there's been good treatments, we're thinking more actively about treating per lesion in a child, and they controlled for an active lesion or a chronic lesion, there's more external, damage. So children have more aggressive, disease. And coupled with this Canadian sort of study showing that, onset of MS before adulthood leads to the failure of expected brain growth for that particular group. They've tried to do male-female differences there. It's quite complicated. But bottom line is that, perhaps, there's some gender component there. But if you get one brain hit, it will sustain your brain growth for, you know, a long period of time. So it's important as such. And we see this both functionally. So although in the olden days, when I was learning to do sort of MS, adults used to tell us, actually, don't worry so much about pediatric MS because it takes them 10 extra years to get EDSS of, you know, 6, which is sort of, you know, wheelchair bound or slightly earlier walking 500 yards. But at one specific age, so a child who's had pediatric MS at 40 is significantly more disabled than a woman that's got MS from age 20. So there is a difference for that age specificity. We know the cognitive sort of involvement there as well. And this is a slide I borrowed from my colleague, Cheryl, who does a lot about sort of the cognitive, you know, sort of aspects of MS. So this is what we used to do before. This was a review from 2016, but you know, that's, you know, almost 10 years ago now, that we would start with first line, you know, treatment, and those were the injectables. If it fails, you go to second line, you know, treatment that is slightly more effective. I'll come back to what first line and what second line is, because it's becoming a little bit sort of arbitrary what first line and second line is. And I think we're quite I think it's really important that these children are managed in a very specific, not necessarily specific service, but in a team that sees, you know, quite a lot of it, because you get a feel about this patient. And we're very lucky that in England, the NHS has commissioned, you know, 5, you know, centers in the UK, and this is the sort of Evelina one. And we've managed to show with colleagues at Great Ormond Street across the epochs, and we had to split the epoch just to get equal numbers across both sides. But in a team MDT sort of approach, and you know, it's common sense type thing, children will be, you know, seen faster, they would have more access to treatment, and more importantly, some of these children, you know, had better cognitive score and less, you know, disability. But this was before, you know, 2016 even. But what happened, as you know, in 2017 and 18, so the game changer is that they published the first randomized controlled trial of efficacy of, you know, MS treatment in children. So this is a big sort of game, you know, changer. So fingolimod, a lot of you know now, licensed 10 and above for any child with relapsing remitting MS. But don't forget that the trial showed that fingolimod is better than interferon. So it is still class 1 evidence that interferon works. So I always remind people sort of in the audience that, you know, fingolimod is better, but, you know, interferon also works. And there's more treatments in the pipeline now. Terrakids has recently been published, teriflunomide. Connect is just fingolimod, has also, you know, just been published. So there are at least 4 or 5, you know, treatments that's going to be sort of licensed now. In the UK, we're very lucky. Twofolds. One is that all the adult treatments are available to children, provided they're post-pubertal. Okay, and you can see there that it's a very busy slide, and I hadn't put that up to go through each and question every sort of pathway, but we generally stratify treatment to, you know, first line injectables, which are usually 30 to 40% effective. And don't forget, all the early trials in MS are done in relapse prevention, whereas now we're treating children slightly differently to have no accrual, or even adults differently, to no accrual of MRI lesions, or, you know, improvement of, you know, a function sort of as such. So you cannot use the old data, but roughly they do translate that if you have 30-40% reduction of relapse rate, there's a 30-40% risk, a chance of reducing new lesions on the MRI. And then the more effective treatments being sort of fingolimod and, you know, ocrelizumab, which is actually not on this list because it's only come on recently. And then the highly effective treatments, which are things like alemtuzumab. Alemtuzumab essentially is a chemical, you know, bone marrow transplant. It just wipes out all your CD52, you know, cells. And natalizumab, of course, which is slightly different in mechanism. It's a sequestering treatment, very much like fingolimod, where it just prevents the cells, you know, from getting in, and by preventing it so effectively, you lose inflammation, you know, in the brain. So this is to show that if you apply it to carefully to children with rapidly evolving. Remember, I told you that all children have got far more active disease. So there's not a child that I see that will not fulfill the criteria for rapidly evolving or highly active, disease if left long enough. So we quite happily, treat them. But of course, we have this group of children under 10 or under 12, if you define how you define prepubertal, that we struggle, to get treatment for. So that's probably in the same lines that some other countries are in at the moment. So in blue are all those, that we can access. So I'm going to share with you some of the data that we have because we've been able to access it, but these are data that is not from randomized, controlled trials. So the big paradigm change in the last 2 or 3 years, as I mentioned, is that nobody waits now for relapses. You measure it by essentially radiological disease, progression. And collectively, we're terming them NEDA, which is no evidence of disease activity, either by clinical relapse, no longer used, imaging, disability progression, not relevant in children because most of them start with an EDSS of 1. And then again, brain atrophy. Hopefully, if you don't get to the level that you're having relapses, you're not going to get that anymore. So the flip is happening now. In adults, you would start with slightly highly effective treatment, but when do we escalate, the treatment? And this is now what we do in children. So I'm showing you some data from our UK sort of data. The first cohort that we did was all children historically. And you can see there that, the highly effective treatments, i.e. the injectables, natalizumab, you can see a reduction in rate, but they were given over a longer period of time, meaning the time to start the highly effective treatment was a lot longer. Now, the second graph from the same collaboration shows that if you start highly effective treatment early, you literally drop the relapse rate more effectively to virtually sort of 0, and they never, ever have a relapse again. And additionally show that there is accrual of benefit in imaging as well. The big question is, how long do you have to wait to show that effect clinically in terms of disability? And the answer is a long time. The adult data, we know it takes about a decade. And there's a recent publication showing that in children, it's also about 9 years before you can show that. And they correlated that with, active, sort of lesions as such. And it's going to take you 20 years to show that it's got long-term social economic sort of gain because, children go to school, go to university, after that. So it's only through these very careful outcome measures that you're going to demonstrate an effect. So that's sort of pediatric sort of MS in a nutshell that, we've got to really sort of treat, pretty early. So in the last 5 to 7 minutes, I'm going to talk a little bit about MOG, which is the new antibody sort of around, as you know. We know that it's found in about sort of, 15 to 40% of patients with demyelination. In the relapsing forms of the condition, particularly with MDEM, virtually everybody is sort of MOG positive. But the frequency of finding it in relapsing patients is entirely dependent on your sampling cohort. In a sort of population cohort, the number is lower. In a hospital cohort, it's higher just because of enrichment of that. And that's the nature of it. And you can look at all the papers that I've, summarized, there. The good thing now is that we're using clinical and radiological criteria in addition to the MOG antibody to make that criteria a diagnosis. And this is a very recent international consensus, and it's really good. It's got all the reviews in there, and that's all that you really need if you want to have a review of cases. What do we know about MOG cases compared to other forms of relapsing demyelination? We know that the MOG patients are usually a little bit younger. Some of them can have a very, very systemic response, particularly in patients from the sort of Asian subcontinent. We find that, have fevers, ESRs, make you think about infections as well. The optic nerve, as you know, and paraclinical features are different from MS. Very little of them are EBV positive. Some might argue it's because of the age, but of course, the links between EBV and MS, and very few of them have intrathecal antibodies. And if they have CSF bands, they are mixed bands, as such. These are the radiological, features of that. I think a lot of you will be familiar, and in the purpose of time, I just wanted to highlight two things. You get a central cord lesion, very much like what you would get in sort of enterovirus, type lesions, and sometimes you get that H pattern that you see in Figure 8. It was not planned that the H was the H pattern for the lesions that you see. And sometimes in the very young children, you get the leukoencephalopathy-like pattern, whereby it's often after many ADEMs that they coalesce. And you can see here that, it's almost indistinguishable. You would worry about a genetic cause of white matter disorder. And of course, those children have been screened and do not have that. So MOG, we used to think is better, they recover better. But actually, relapsing MOG has a higher disease burden compared to MS. So for a child that has had MOG with a relapsing course for that same period of time and the same amount of relapse as patients in MS, they have a higher EDSS score. We know that. The second thing we also know now is that, a lot of the typical MS treatments do not work in those patients, whereas the more steroid-sparing agents and rituximab works better. And you've obviously heard the odd one out there being IVIG, that appears to be highly effective in this group of patients and remains the only treatment that we know that will actually switch off MOG very consistently across the board. And also showing that of the cohort that we did so many years ago now, it's the IVIG that incurred a benefit. So it probably switches off the relapses enough for them to gain, skills, whereas all the other conditions, if you were relapsing, you would start to lose, skills. So it led us to think that, okay, this was the algorithm, and probably still is common practice. But in the last 2 minutes, I wanted to challenge you to thinking a little bit about what might happen in the next 5 years. So we say, we would not treat every single demyelination that presents, MOG that presents, because 30% of them relapse. So there's 70% that doesn't. So if you put them all on disease-modifying treatment, you're going to be over-treating, the 70%. We also know that a lot of them recover very well. So the typical feature of MOG-ON and MOG-NMO, TM, despite the severity of presentation, is that within a week of steroids, some of them would be standing up and some of them would be, getting back to sort of normal vision. So you would challenge the notion as to whether there's actually demyelination rather than myelin inflammation as such, but we don't need to go there. So we tend to only reserve that for, the second sort of relapse. But let's go back and think, a question that a patient often asks me is, how many relapses can I have before I have a problem? And this is the NMO sort of data from many years back in the French Martinique island, where treatment was not sort of available. And of course, they were perhaps had some Caribbean sort of background, so the response to inflammation might be slightly different. But we know that about 3 spinal relapses will not guarantee, but you'll be pretty certain that you'll be in a wheelchair, and 2 optic neuritis, you'll be counting, sort of fingers. This is aquaporin 4, of course. But, is MOG really that much different? And this is a data from MOG, but adults, let's phrase that. And it shows you that complete recovery. So again, I'm stressing complete recovery, not importance of partial sort of recovery. If you look at MOG and if you look at downstream, first event, you got about 50% chance, right? Second event, it drops very, very significantly to about 25% of full recovery. And then if you look at stratify it to conditions as well, TM and ON, pretty good, virtually everyone recovers. But the second hit of TM and ON, very, very few sort of recover. So the second event is quite an important event. So how do we consolidate that? We also know that in children, brain growth is affected. This is almost a study that you can predict. I almost stopped wanting to do any of these studies. Any form of brain inflammation that you have in children will sustain abnormal sort of brain growth. But we can define the cognitive problems, and we know that children with MOG, at least 50% of them will have some cognitive impairment. I think the acid test here is being able to find predictive markers of relapses. All these studies are, let me stress, adult based. So these are the protective factors of relapse, not disability. And we know that at first serum measurement, if your titers are very high, your relapse risk is pretty high. Child and adult, not significant enough to make a big difference between the two. New silent MRI lesions. This is the most interesting, bit here. But that cohort is an established cohort of relapsing patients already. So we know in those cohort, it happens in a very small proportion, but within 2 months of finding a new signal, patients relapse in an established cohort. Can we apply that to every patient? We don't know yet. The Canadian data from many, many years ago now that's hidden somewhere, nobody appreciates it, shows that about 20% of patients with active lesions relapse. So the numbers are not, sort of big as such, but the treatment then was sort of quite different. So we're evaluating that again. I suppose what I'm saying is that if you take all that into consideration, maybe we should be thinking about moving to offering some patients disease-modifying treatment. Those who recover poorly from a first attack, for example, additionally have a significant risk of relapse. But is it reliable enough? I think it still needs validation. But I'm pretty confident that, us as practitioners don't really like to sit down and do nothing until the next sort of relapse. And it's just to also stress to you that I think our mindset needs to think to maintaining no, disability rather than maintaining minimal, disability. And the only way we can do that is to hit, as early as possible, but in the right group of patients, of course. So I'm just going to end there now. And again, apologies. I seem to take extra 5 minutes all the time. So most conditions are recognizable, and the two paradigm change that I mentioned: early treatment in MS. Why are we waiting for MOG? Maybe we should adopt it in some way. Thank you.
Thank you very much for your excellent presentation. The topic is is amazing and very hot, and everyone has many questions. But unfortunately, we are requested to close our session because we are running short of time. And then, but we can make the questions after closing the session. Is it okay? Okay. You are all invited to have. Thank you very much for all speakers, for all audience, and you are now invited to have a coffee break. Thank you very much. Could I rush?